Our next speaker is Dobbie. Anna is very busy and she splits her week 3 days between adults, peds and flying with London Hems here in your local stomping ground with the Royal London Hospital. So Anna's going to share her pearls and pitfalls about how we can manage paediatric trauma team leadership better, so how we can do that. And Anna, thank you very much.
So what does it mean to take it to the next level? Back in 1985, I really thought that this snazzy little combination of my favourite drop-waist sailor girl dress with my decorative ABC headband was taking it to the next level. Now, retrospectively, like many things in life, as time moves on, my definition of taking things to the next level, particularly when it comes to fashion, has changed. But like your trauma team leadership, you develop a style which evolves and changes over time. And even if you have loads of experience, we can all still improve. When thinking about trauma team leadership, and in fact, any sort of leadership, whether it's the paediatrician on the peds ward leading a peds resus, or the surgeon with the acute bleed, or the neonatologist leading a team of people with an extreme prem intubation, then being able to lead a team of people that have probably never worked together before and taking that leadership to the next level is when you can produce the best possible care for that child. But also, so everybody in that team comes away from that thinking as though they've delivered the best possible care that they were able to. Thinking about bad outcomes. If the outcome is bad for the child when a child dies or is left severely impaired, even though that is really dreadful and it's a disastrous thing, if you and the team have worked cohesively together and done everything that you could to provide the best possible care for that child, then it makes it easier to deal with. It's the ones that didn't go so well that leave you with that horrible, sick feeling in your stomach when you mull it over and over again. And this is why we always need to try and take it to the next level. So, imagine in the facility where you work, there's a trauma call coming in. It's a 13-year-old girl called Saskia. She's been clipped by a car, travelling at about 15 to 20 miles per hour. She's got some pins and needles in both hands, and she's complaining a little bit of neck pain. So what do? The first part is to make sure you nail that first 2 minutes. I was talking about this talk with one of the ODPs from work, and he obviously sees lots of different styles of team leader. And he said, you know how it's going to go from how they take the patient off the scoop. The first 2 minutes sets the tone for the rest of the call, so don't risk losing your team before you've even started. To my husband's utter horror, I have no idea which way round which the pedals are in the car that I drive. And I drive an automatic, so there's only 2 to choose from. But because driving a car is so automatic for me, for the past 24 years, I've been able to get into the car and drive it, for the most part, relatively safely, because I've done it so much and over again. And so this allows me to get in the car, drive the kids to school, while simultaneously practicing spellings, avoiding all these crazy lycra-clad cyclists, of which my husband is one of them, and fantasizing about what life could have been like had I married George Clooney. It's the same with my trauma calls. They're the same every single time, and I do it in the same way. And the reason I do that is because when the really hideous trauma call comes in that makes you feel sick to the stomach, and you need all your bandwidth to concentrate on what you're doing and how you're going to treat the patient, then the rest of it just comes out like clockwork. It also gives you something to fall back on if something puts you off your stride or throws you, if you know what you're doing in those first 2 minutes. So, for every single one of my trauma calls, I try and do it perfectly. I make everybody put on lead aprons and plastic pinnies because that's what we're supposed to do in our institution. And we take the patient off the scoop as the first thing that we do. And we take the right side of the scoop out first. So when the pre-hospital team come in, I greet them. I say, hello, my name's Anna Dobbie. I'm the trauma team leader. If we can get the patient across, and then we'll hear what's going on. And so it sets the tone from the start. Everyone knows who's leading the trauma call, and it just gets it going cohesively. Once the team have given their handover, I don't ask any questions. That can be done later on and just delays your immediate assessment of what is potentially a really sick child. But what I do every single time is make a point of thanking the team that have brought the patient in, as don't underestimate how daunting it can be to present to an entire assembled trauma team. I then turn and focus solely on the patient. Now, I've managed to develop a little habit of starting every single trauma call with a little, right, folks. Now, I'm not a how are we doing, folks type of girl normally, but it's just something that's happened, and it's now automatic, and I quite like it because I do it at the beginning of every single trauma call, and it just grounds me, it calms me down, and it sets me up to lead the trauma. But now I can't say right, folks, without that little hand gesture. So every single trauma call, I do exactly the same moves to take the patient off the scoop. Right, folks, can we take hold of the head at the top end? Can we split the scoop top and bottom? And we're going to take the right side of the scoop out first. So can I have 3 people down the patient's left-hand side? And we're going to have all hands over because we're bracing, and we're going to take the right-hand side of the scoop out first. The command from the top end when you're ready is going to be ready, brace, remove. And the right side of the scoop comes out. If we can have those 3 people down the patient's right-hand side, we're taking the left side out. And again, the command from the top end is going to be ready, brace, remove. Great. If we can re-secure the head, if we can have a set of observations, please, and if we can have a nice, loud, clear primary survey. It's the same every single time. The way I've described is just the way that works for me. I'm never going to suggest that everybody goes around starting their trauma calls with a right, folks. That would be ridiculous and a bit weird. We don't want a whole bunch of clones. You need to find a style that works for you and build and grow that. Back at school, I learnt tap dancing, and I can still bash out a time step at the drop of a hat. Go on then. Shuffle, hop, spring, tap, step, step. Shuffle, hop, spring, tap, step, step. Shuffle, hop, spring, shuffle, step, shuffle, ball, change. Jazz hands. And it's the same with your trauma. You need to find your own style, but learn those same moves time and time again. Practice really does make perfect. And if you work in a place where you don't see much paediatric trauma, then use other means to practice. So maybe run a sim and use and focus on the first 2 minutes in the handover. Or go through it in your head time and time again as you're driving to work, in between avoiding those cyclists and fantasizing about old George. Right, so Saskia, fortunately her symptoms settle down. You can't find any injuries, and you decide to pop her on the observation unit, and you're going to go back to see her again. You start fantasizing about that mid-morning coffee that never actually comes, and Sister comes up to you and says, I'm afraid we've got another trauma coming in. This time it's Thomas. He's a 3-year-old boy. He's fallen from a 2nd-floor window onto concrete. He's lost consciousness for 10 minutes, and he's coming into you with a GCS of 12, and he's a little bit agitated. Now, what scares a lot of people when they're leading teams is they don't always feel as though they're the most qualified person in the room. And how do you lead a team and stay in control if you don't always know exactly what you should be doing? I think it's very rare that you can stand in a room full of a trauma team and say, actually, I know the most out of everybody here. I know more paediatric trauma. I know more peds surgery. I know more peds anesthesia. I know more about safeguarding. I know more about play therapy than anyone else here. It doesn't happen. And that's why we have multidisciplinary trauma teams, as everybody brings their own strengths and skills. The other thing about peds trauma, particularly the really serious stuff, is that nobody is 100% comfortable. It's a rare event. So those of us from a predominantly ED background are like, oh my God, it's a really small child with trauma. And those of us probably from a paediatric background are, oh my God, it's trauma in a small child. So nobody's 100% comfortable. Use the experience of those people around you and look on it as a great thing that you can foster opinions from those that have particular expertise. Be prepared after those same initial moves to potentially change the plan. Patients are dynamic and things change. And at the end of the day, it's about the patient, not about you. And so be flexible. And if you're gracious about that, people will respect it. I'm always grateful to have colleagues at the back of the room when I'm leading a particularly tricky trauma, as often those who are not directly involved can have a bit more clarity and headspace to think through some of the trickier situations. The way I find useful to stay in control whilst using those around me is to verbalise the conundrum that's going on in my head. So after Thomas's primary survey and his observations and perhaps a bit of intranasal diamorphine, I might say, okay guys, so Thomas has fallen 20 foot onto concrete. He's lost consciousness for about 10 minutes. He's come into us with a GCS of 12. He was a bit agitated. He's settled somewhat with the intranasal diamorphine. Now, we obviously need to scan his head and neck, but do we feel, in view of his mechanism, that we need to scan the rest of his body? And also, do we think that we need to RSI him for the scan? In that way, you can get the collective opinion of everybody there, and then use that to make your decision. Even if you are the most senior person in the room, I still find it really useful to verbalise these conundrums, just to give you a bit of a sense check and make sure that you're making the right decision. Once you have a plan, you then need to bring this group of people and produce a well-oiled, smooth trauma team. You're aiming to produce the slickest pit stop that you've ever seen. And there are many different entities to this, from how you train people to be in the trauma team in the first place, to just how they're performing on the day, depending on how their day is going. The way I find useful to bring together your team of people so that you're all working towards the same goal is to set timeframes. Okay, guys, Thomas has a potentially time-critical head injury. I'd like to be in the CT scanner in the next 15 minutes. The time now is 10:15. So what we need to do is we need to get the RSI checklist ready, we need to get the portable monitor, we need to get the portable ventilator, and can you ring the radiologist and get the scan protocoled? In that way, the whole team know where they're going and why. As the team leader, you've now offloaded these tasks, and it gives you the chance to look a little bit further ahead and think about what I call the what-ifs. Okay, so we're going to get Thomas into scan, and if Thomas's scan shows a head injury that's amenable to theatre, then we can go straight to theatre from scan. So in order to do that, we need the theatre transfer checklist, we need the neurosurgeon to be in scan, so is he or she on their way down? It'd be really nice if we could get Thomas's parents in to see him before he goes up to theatre, and when would be the best time to do it? On the other hand, if the scan doesn't show an injury that's amenable to theatre, then we need to go back to resus. We need to optimise his neuroprotective strategies. It'd be really good to get his parents in to see him, and let's speak to the neurosurgeon about potentially putting in a bolt or waking him up to monitor him. Simon Sinek is a successful businessman and life coach. He gives a fantastic TED Talk on what makes a great leader. And his main point is that a really fantastic leader isn't authoritative. A really effective leader creates an environment of trust which enables the people in their team to work at the very best of their capability. So the most important part about all of this is how you behave. Just prior to the anaesthetic, Thomas suddenly deteriorates. He drops his GCS down to 3, and he blows a pupil. Suddenly, the whole situation is even more time critical, and people are under intense pressure. Shouting at somebody because they can't draw up the right dose of hypertonic saline is never going to enhance their performance. And I've seen people physically shaking when they're trying to put in a cannula because they're so anxious. The way you react and perform under intense pressure will shape you as a clinician and is the truest test of your team leadership. The sickest patients need the calmest leadership. So, we all react in different ways when we're under immense pressure or stress. Some of us go quiet and insular, others become angry and shout. Whatever your reaction, you need to take a moment to acknowledge it. Take a deep breath, and then go slower. And use all the tools you have, like verbalizing the conundrum, talking about timeframes, or thinking about the what-ifs, to continue providing calm, efficient care. Deep breath. Right. Okay, guys, so Thomas has got a bit sicker. We need to get that RSI done nice and quickly, but let's run through that checklist to make sure we're nice and safe. Nikita, could you go to the scanner and make absolutely sure it's clear so that we can go straight in? Tom, can you draw up a dose of hypertonic saline for me and give it? And Bethany, will you ring the neurosurgeon and tell them what's happened and get them down here straight away so they can come to scan with us? In this way, Thomas continues to receive calm and expedient care. When it comes to leading trauma teams, particularly under intense pressure, then none of us get it right every time. I've been doing this for a little while, and I'm still learning. Never underestimate how useful it is to watch other people leading trauma teams. I love watching other people, and I can always take little bits to enhance my own performance. Everyone always seems to want to be the trauma team leader, but actually, the benefit of watching as many good and bad team leaders shouldn't be underestimated. What is most important is that you have your own moves learned so they are completely automatic. And then you can find your own style, but make sure you know those dance moves, and then you really will take it to the next level. Thank you.